Welcome to the 21st Century Physio podcast. We've got a really exciting episode in store today. We've got Diane Jacobs all the way from Canada. Probably the beauty of technology is we can connect with people all around the world these days. So someone probably on the totally opposite side of the world to where I am now, and someone with a remarkable extended career over a long period of time. So I'm really looking forward to some of the great things that she's got to share with you today. So welcome, Diane.
Thank you, Stephen.
So Diane, for the listeners who don't know who you are, do you want to give them a brief introduction about yourself and your journey throughout your physical therapy career?
Well, I'm a Canadian. I live in Saskatchewan, Canada, which is just pretty much in the middle of the prairies, the big flat part in the middle. About 1 hour north of the U.S. border with Canada. I like to call it the deep south of Saskatchewan. And I studied in Saskatoon, Saskatchewan a long time ago, graduated with the class of 1970. Wow. So probably before you were even born, I'm guessing.
A fair way before I was born, correct?
Yeah. So in the year 2020, I will have been a therapist for 50 years.
Wow, that's remarkable.
Yeah, I don't know where the time went, but anyway. And I still practice. I still have a solo practice. It's a one-woman shop, and it's in an extremely favorable situation. I'm kind of under the wing of another physiotherapy clinic, and the woman who owns that clinic, and she allows me to have my own practice inside of her clinic, and all I need is one room. And it's sort of a semi-retirement practice, so I only work in the afternoons, It's quite wonderful, actually. And plus I travel and teach. So I have some leisure time these days.
You're keeping pretty busy still, though, by the sounds of it.
I am, yeah. Yeah, quite busy.
So 50 years, that's a long time in the profession, as long as probably anyone going around in the profession at the minute. What's the difference you see from back in 1970 when you started to modern practice today? There's some massive changes, I imagine.
I think, there have been big changes. When I graduated, way back, it was all about having been taught how to be a physiotherapist in order to work in a hospital. That was all there was to it. So, I wasn't completely thrilled about that. I graduated and have my license to touch people, and had a job in the hospital teaching people to crutch walk and that kind of thing. And stroke rehab, that was another big area. Respiratory care. Physiotherapists used to do all of that before respiratory therapists came along, and then they took over that whole thing. But the work in a hospital was like full of having to deal with lots of other people that were also working in the hospital. It was less like the patient care aspect was a big chunk, but then there were all this other, lots of other people to deal with. And as an introvert, I found that really tiring. And I really did want to become a manual therapist. That was kind of what I thought I would learn in physiotherapy school, but it didn't quite turn out that way. So after about 12 to 13 years of being a hospital physio, kind of around 1982, 83, there was a big tsunami of orthopedic manual therapy that suddenly hit Canada, and it became such that if you didn't study these workshops or go to these workshops and learn all the minutiae about joints and ligaments and so on, you were kind of considered not a very good physiotherapist anymore. It was like, because we had up to then just been these people who coached and applauded and praised and cheered on people to do their own thing without any hands-on really, or minimal, just enough to keep them from falling down and being an insurance issue in a hospital. So anyway, so I was interested, but at the same time, kind of swamped by all of the theory of orthopedic manual therapy, which seemed to boil down to pain came from joints, and you had to learn how to move joints around passively. And now in the look, then a whole lot of time went by, and it was like, oh no, that's not so important as we once thought. Once pain science came along, thank goodness, we could kind of go back to being manual therapists who worked with pain and not had to worry too much about joint movement or any of that stuff. So, yay, hooray! In going back to 1982, 83, when manual therapy finally kind of took over Canadian physiotherapy, I took a different track. I looked at it for a while, but wasn't thrilled and took a different track. I moved to British Columbia, where kind of the mecca of manual therapy in Canada was at the time, but only so that I could be closer to a school, which was just over the border in the US, that was run by a doctor of osteopathy. And in the US, these are medically trained doctors who also do manual therapy and in his case, teach it as well. And I liked that kind of way of working, the slower way, the more careful, kind of like palpating for changes as opposed to trying to palpate for joints. So it was slower kind of soft tissue work, and I was much more adept at doing that stuff than trying to figure out which joint was moving which way or whatever. Anyway, so I learned all sorts of cool stuff there. Went down several dozen times probably to take workshops there from Vancouver. And so from about 1985 to about 2002 or 2003, that was the span of time that I studied with this guy. And around the year 2000, there was a big shift for me, which was David Butler came to town. He came to Vancouver, and he started talking about nerves now. And it was kind of like this giant light bulb came on. I thought, oh my gosh, that's what we've been working with all this time, even doing all this superficial kind of skin stretching stuff. It's been about the nerves. And that started me on this trajectory, which I'm still on, which is that any kind of manual therapy, it doesn't matter what kind of manual therapy you're doing, it's about the nerves, hello. And it's about making sure they're happy in there and not crabby. And so there was a missing piece. Okay, so the osteopathic stuff had been very helpful in helping me learn to use my little hands on people, but I didn't understand how the nerves got into the skin from the depths of the body. So I had to go and beg and plead at the University of British Columbia to have them allow me to do a dissection so that I could understand how cutaneous nerves disseminated to the skin, and that there just wasn't anything in the literature. Nothing, except 15 papers, which the Physiotherapy Association, the librarian there kindly dug up for me. But they were in German or French, and they're mostly by plastic surgeons, and they mostly were about the cutaneous nerves of the face and the breast. I mean, that's what plastic surgeons kind of are busy doing most of the time. I think that's their bread and butter. Anyway, so there was nothing about the rest of the body, and the dissection totally changed my appreciation for cutaneous nerves. It was like another light bulb went on. So ever since then, I've been like, come on, let's talk about nerves, but let's talk about how cutaneous nerves are just as important as any other deeper motor nerve might be. In fact, probably more so in terms of pain and central sensitization and all these other things. So that's kind of it for me. I'm a nerve girl.
So from those dissections that you're doing, what were some of the big takeaways, or what were some of those light bulb moments that you thought, oh, okay, that makes a bit more sense now?
Oh, well, that the skin is an organ, for one thing. It's not just this thin layer of saran wrap around the body or anything. No, it's thick. It's really thick, like super thick on people. And the specimen that I was allowed to dissect. I just did one arm. And this was an older male who died of something, I don't know what. But he was not a very fat person, a nice lean guy, old guy. But the skin organ on his arm, I mean, it was this thick on the forearm and it was about that thick on the upper arm. So it's like a super thick organ.
Yep.
So it's three-dimensional and it slides around, but it's tethered to the deeper fascial layer with skin ligaments that kind of allow movement but don't let you have too much movement.
Yep.
And through these skin ligaments, some of them which are tubular, the nerves project outward to the surface of the skin. From there, they ramify massively and interconnect.
And so when we're doing manual therapy, what are we actually doing? How is it working? How do you explain it to your patients and clients?
Well, the skin is sensitive and neurons are highly excitable. They're the most excitable tissue, in quote marks, of the body. And so, you can shut your eyes and you can feel a butterfly land on your arm. So it's, if your mind is prepared and you're expecting it, otherwise if you're distracted, you might miss it. So preparation of person is kind of important, right? You kind of set them up for what's going to happen. And so that was a big thing I learned. And the whole thing about, I mean, the skin is just ignored completely in manual therapy. It's crazy, right? But it's like the highway to the brain. The dorsal column columns in the spinal cord are conveying all this information at this really rapid, I think 430 kilometers an hour or something. And just like single neurons that go all the way span the distance between your big toe and your brain. I mean, hello, it's like, it's going to be fast getting the information in there through the skin. I do think that manual therapy of any kind, and I don't care what kind you're doing, that's how it works. I mean, I'm pretty sure. I don't see how it could work any other way. And in a conscious, awake, alive person who has sensibility and not in coma, not knocked unconscious in order to have an operation. We are not operating on people. We are interacting with nervous systems.
And so where does that fit into, a 21st century physio paradigm? I guess there's a lot of, talk, a lot of social media these days is very anti-manual therapy. Where does manual therapy fit in today in practice?
I don't think that people are as anti-manual therapy as they are anti the really outdated explanatory models for manual therapy. I don't think anybody in our profession would ever claim to never put their hands on people or try to help them that way. It's a touching profession.
Yeah.
So I do think a lot of people are against the really outdated explanatory models, and they are trying to take that ship and put it upright and say, no, we got to get realistic, rational, and we have to promote self-efficacy and independence in the patients.
And what do you think this understanding has taken, so long to come into the profession? Like, obviously, you're talking about it with, David Butler spread his message back in, late 90s, early 2000s. And, I know still going through physiotherapy and going through some of the courses, this stuff still isn't integrated into there, and the understanding mechanical.
I know. I guess it takes a long time. I don't know. But, I mean, pain science took a long time to get going, too. There was a great deal of furor over the 1965 Melzack and Walt paper about gait control theory. They had backsplash from that and pushback. The anesthetists and the anesthesiologists kind of figured that was cool, though. They knew something about descending modulation at that point. But the rest of the medical profession was a little upset because it overturned, 400 years of biomedical model and all of that. So, and that's only 50 years ago. No, 60. How long ago is that now?
Almost 60 years.
1965, we're talking. That would have been more than 50 years ago now, 54 years. So actually 50 years doesn't seem like that long from the perspective of an old physio. Anyway, but yeah, I mean, it seems like it has burgeoned and taken off, but it still hasn't, like water, it still hasn't leaked into every facet of every hands-on profession out there yet.
Still a lot of room for improvement, definitely.
I do think so.
And so where do you think, obviously there's been some big changes, like that over the last 50 to 60 years. What do you think the big change is going to be over the next, 10 to 15 years in the profession in a shorter time?
What I would love, what my fantasy is that physiotherapy becomes more therapy and less physio. And not ever leaving away hands-on, I mean, but rather developing incorporating from other fields of life about how the therapeutic relationship is kind of the critical piece here. Making that central. Pain science and the therapeutic relationship. Taking those two things and making a new profession, or kind of evolving our profession with those two things as fundamental core trainings or something.
Yeah.
And, way less of, I'm glad the electrotherapy thing has kind of died off. There's not really much of that anymore. Yet every single school still has all this shortwave diathermy and stuff stuffed in their cupboard, that they drag out because they still have to teach it even though it's irrelevant. But, and ultrasound, all that stuff, right? Oh, if I had back all the hours that I spent learning the wiring diagrams of that machine. Back in school. But anyway.
No, I can definitely relate to that.
Yeah.
Dave and Lorimer in one room, sort of teaching us the latest pain science, and then he'd walk straight out of that class into the therapy class.
It's insane, right?
Yeah.
Anyway, there needs to be a renovation or something of the professions and bring it into this century. Yeah. And yes, you still need the anatomy classes and the pathology classes and all of that, but there needs to be kind of a bigger frame around the profession such that the ingredients of the profession are not taught as standalone things. Are kind of like this frame. It means that, yes, you have access to this information, but it is not what physiotherapy is, right? Yeah. Physiotherapy itself should be all about the interaction between a patient and a therapist. And I don't know, some people are even saying, let's get rid of the word patient, and I kind of maybe that would be a good idea. Some days I think it would be a really good idea. Other days I think, it doesn't really matter. But I don't want to necessarily go to just only the word client, because that would make us back into being massage therapists or something.
Yeah.
But I don't know. Maybe we need a completely new word that is neither patient nor client. I don't know.
Interesting you bring up the word massage therapist. So I guess they're applying similar techniques to physiotherapy as osteopaths and chiropractors. What do you say the difference is between all the professions and what physiotherapists do compared to?
I think massage therapists are the oldest one of all of the hands-on professions. In fact, physiotherapy and massage therapy used to be all one thing until it split apart. And physiotherapists decided that they were more interested in the joints and cracking them and stuff like that. And there always had been a few kind of like manipulative therapists in the profession all along. I think that stems from the British Army trained physios from centuries ago, still kind of like embedded in, for Australia and Canada at least. Embedded in the profession in few numbers, but then suddenly the numbers exponentially increased of people that were interested in doing that to people. So I've never been a fan of manipulative therapy, as you can probably tell. Just seems too operative. But anyway, be that as it may. So as far as massage therapy goes, I always have thought that I probably would have been a happier individual had I been able to study massage rather than physiotherapy. But in my life at the time that I was ready to launch myself into adulthood, physiotherapy was the only school that was accessible to me where I lived. Now there are massage therapy schools around, but not then.
And so why do you think you would have been happier?
Because of the gestalt kind of massage therapy. Okay, so these are the massage therapy profession. It's got big hills to climb too, but generally speaking, the people who are in the profession are sensitive individuals who do care about their clientele and are wanting to do their best, and they're very touchy, and they're very human primate social grooming, I call it. I call what I do that too. As in that we are mammals, and mammals hang out and handle each other and cuddle and do things. It's a social event. It's a psychosocial bond building effort that mammals do. And well, actually, any two vertebrate species, it doesn't really matter who's in it, but I teach teach workshops about how, if you're a vertebrate, you're going to get cuddly up with, the cats particularly are irresistible. The cats will hang out with anybody, including lizards and reptiles and Lordy knows what else. So really, there's nothing in our intrinsic hardwiring that is against contact, physical contact. It's there. Culturally, we have it beat out of us for the most part. Big boundaries, and then you have to have your license to touch people in order to be able to do it. But anyway, massage therapists are kind of instinctively ready to go forth and touch people, and it's like it's a calling. And there's a lot of people in massage therapy, really interesting people who've left other careers where they made gobs more money and had gobs more responsibility and had, heads of corporations and all kinds of, and academic people who finally got tired of the rat race and became a massage therapist because it is a peaceful way to make a living, and it's less stressful, it's healthier on your own nervous system.
Yep, definitely. And so when you come back to this, enjoyment factor, you've been doing this now for almost 50 years. How do you keep that, enjoyment? What's your tips for young therapists out there? Because I often see, and I get a lot of emails myself, people who are 2, 3, 4 years out, they get to this point and they're just like, look, I'm not sure if this is me. I might go back and, study accounting or go and do, business, or go and do a PhD. They sort of lose that interest and...
they lose that loving feeling.
They do.
And you know what? I think that's fine. If they don't want to do it, then they shouldn't be doing it. Just like people who don't want to be parents should not have children. It's like, okay, when people sort themselves out, and it's fine if they make a mistake, pick the wrong thing to do first, right out the gate, and then change their mind later. It's okay. Maybe they'll be a fabulous, real estate agent or whatever else they decide to do with themselves. It's okay.
Yeah. And how did you go? Because you said the first, 12, 13, 14 years of your profession in hospital was probably not doing, what you'd intended to do, what you thought physiotherapy was going to be. How did you get through that period?
Oh, I quit a lot. I did. I did try on other careers, and I did go back to university quite a bit and study other things. And I studied art. I studied sociology. I even studied pre-med.
Oh, wow.
But I decided that was probably not a good idea, just be back in the hospital again. Yeah. Anyway, but physiotherapy always took me back again, and so it's been a lifelong. I would start to miss it after being away from it for a year or whatever. It was always easy to get a job. There was always like a desperate need for somebody in there to teach people how to crutch walk,
Yeah. That's great. So who's been the biggest influence in your career over time? I get the impression that David Butler obviously had a big, impression.
Well, he kind of was a pivotal force, yeah.
Yeah.
And I remember in that class, I think it was 1998, and I sat there, and he looked at me and he said, "You're thinking, aren't you?" And I said, "Yeah." He says, "You really are always thinking, aren't you?" He didn't know me. That was the first time I'd ever come to his class, but he had pegged me as somebody who sat there thinking. And really what I was doing was sitting there coping with all the cognitive dissonance that I was experiencing and being simultaneously fascinated and overwhelmed and excited. I mean, just all three things at once.
There would have been a few myths being busted in that class, I imagine.
I hope so.
Yeah.
Mm-hmm.
So what are the biggest, if we go back to some of the myths, I guess, around physiotherapy, what are some big ones that you've seen change over the last 10 years that have, things that physiotherapists held true, which now we're sort of realising that that's not the case?
I have been overjoyed at several things, but the one that stands out the most is all the emphasis in Canada anyway that was put on palpation accuracy. And it turned out it was just a big myth. And it turned out that no one had the right to stand there and say to somebody else that they couldn't palpate, and that they, assuming that they themselves could, and that the other person was doing it wrong or whatever. Like all that stuff has been shot to dust, and I loved it. When the studies came out that there was no inter-rater reliability and all stuff, it's like, great, I knew that. Anyway, so that, and the whole emphasis on, if someone comes in and they have pain, that must be coming from some tissue. Like, I just loved when that one went away. I mean, it hasn't gone away entirely, but it's going away, and that's a good trend.
And do you think? Oh, sorry.
I was going to say also, I had the opportunity and the pleasure of sitting in a workshop taught by Peter O'Sullivan a couple of years ago at San Diego Pain Summit, which is coming up next week.
Yeah.
Wow. Anyway, and I loved it because here's a guy who I assume used to be quite transversus abdominis kind of guy, right? And there he was, and he had to believe his own data and backtrack from being super enthusiastic about whatever transversus abdominis was supposed to be about. And he had to backtrack and believe his own data that said it had nothing to do with anything. And that now he's like, yeah, well, don't brace. I love when stuff like that happens. It's kind of like going back to the old days when we were coaching and attending and encouraging and helping, without demanding.
I think that's definitely where the profession's heading. I think more that sort of coaching elements and, forming that team is to that therapeutic alliance with someone and delivering the best, all-round care. So I really like that philosophy there. So what do you think what sort of skills do you think someone needs to be a good physiotherapist in the 21st century?
Well, A, you have to be a decent human being. B, be willing to be open to change, be flexible enough that when these kind of new and quite irresistible and irrefutable new ideas come along, that you'd be able to switch horses midstream and go the new way, the way that science kind of is hurting us. That you be able to be capable of determining your behavior and your interactions with patients and people who come see you based on scientific plausibility, not necessarily that you have to, this has to have evidence or this. No, but just it has to be coherent, rational, scientifically plausible, and then take it away. And be a decent human being.
It's a pretty good tip, I think. It's probably a good place to start.
It's a starting place.
So how do you avoid jumping on the fads through your career? As you mentioned, you've been through the
Oh, I jumped
electrotherapy
on a
phase.
few.
Yeah,
I jumped on a few. Oh, yeah. I learned my lesson.
yeah. So it's just a learning thing over your career. You just,
I think you just learn to sort better.
Yeah.
Yeah.
Okay. Very good.
And yes, and smell smell it in advance. Oh, that's probably not a great idea because it doesn't fit with all this other stuff that I do think is real.
Makes it tough. So we haven't touched on it yet. Neuromodulation and your courses. What is it? And what do you teach in your courses?
Oh, I came up with the name with some help. I was on a discussion forum for years and years called Soma Simple, and people there helped me find a name for the different concepts that all seem to fit together into a package. And it's just about touching people in a kind way and in a non-nociceptive fashion and in a non-nociboic way. So there's always two things. There's the nonverbal part of the treatment and then there's the verbal part. But in neuromodulation, it's all kind of one thing. So if you're talking, it doesn't matter what kind of manual therapy you do, right? If you're talking about skin and nerves and brain and spinal cord and the person that is embedded in all of that, then you're talking about neuromodulating. And the other technical aspects don't really matter.
And so you've got some courses running down in Australia, in the next few months?
Couple.
What do people expect to get when they come to one of your courses?
Well, they're going to get a whole whack of neuroscience, and the emphasis is going to be on the sensory nervous system, not the motor output system, because really that's secondary, in my opinion. In a manual therapy context, it's secondary to the sensory nervous system. You do want to persuade somebody's sensory nervous system to like you as a therapist any way you can, through your contact, verbally, psychosocially, and physically. So it's the foundational kind of mechanisms. I have completely adopted the neurodynamic kind of like explanatory model. So that's embedded in everything I'm teaching, except there's not a lot of emphasis in the classic neurodynamic model for cutaneous nerves. Okay. So I just added that in. Hey, whenever you're moving skin around, you're pulling on these cutaneous nerves and you're actually mobilizing them. And it's going to affect their circulatory, the neurovascular thing. They're all kind of entwined like that anyway. So you're going to be mechanically stimulating all of that stuff that's mechanosensitive. And that's kind of, if you want to think about it purely like operationally, that would work. But there's so much other stuff to it. There's the whole predictive brain processing model that I teach a little bit of. I throw in some Anil Seth video, with his conceptual hallucination. Throw that in. And a little bit of the history of pain science, the neuromatrix model for sure by Melzack, and the idea of physiotherapists or manual therapy being a way of providing a predictive brain with some afferents, an environmental stimulus, so that it can then make a new prediction. And talk about that way. Talk a lot about descending modulation and spinal cord and how really the brain, the big fluffy brain at one end of the spinal cord, is there to inhibit the spinal cord in every which way, all the reflexes of the spinal cord, which will take off if allowed to. But if you can get the brain persuaded to come back online and inhibit the spinal cord, then that will inhibit the nociceptive aspects of existence and persisting pain, a lot of it anyway. Oh, and I also teach that there's no point in trying to use manual therapy for kinds of pain for which manual therapy is of complete, not useful for. So the kind of pain that it is useful for, which lucky for us manual therapists out in the world, all in our plentiful numbers, is the kind of the neurogenic kind of pain that is confined to a region of the body, changes with position or rest. It's mechanically sensitive. And that kind of pain, no matter if it's been in you for a year or 10 years or 20 years, it can be affected by manual therapy and improve and resolve even. So I do keep it confined to that's kind of pain you manual therapy is good for. Don't try to use it on these other kinds of pain because it won't work.
Yeah.
And so try to take a good history and figure out what you're doing.
It's always a good place to start.
Yeah, and follow up. Okay, so follow up and kind of movement therapy for home. Teach all about that too. And sort of it's process of clinically reasoning your way through a problem with somebody. So somebody comes in and they have a particular pain in somewhere in their arm or leg or whatever, or back, whatever. And so finding out about their habits, what they do when they're resting, especially because when a body is resting, it has mass, there's gravity affecting it, there's air pressure, 32 pounds per square inch still affecting it. So the nerve, some portion of the 72 kilometers of peripheral nervous system is going to be affected by how people not only use their bodies, but how they don't use their bodies. So I call it the default resting position problem. And there will be people that have their habits and they always maybe cross one leg but never the other, or they sit leaning on one elbow but never the other, right? So they indulge themselves in asymmetric behavior. Doesn't matter it doesn't matter if the body is asymmetric. It doesn't really matter at all. It matters that they use gravity and air pressure and all these other things symmetrically. So behavior.
Yeah.
Changing it up, sleeping on both sides, not just one side all the time, just because you don't want somebody's breath on your face or whatever, So learning to adapt, cook yourself on both sides like a pancake so that you're not burnt on one side and raw on the other, kind of thing.
It's a nice analogy. I like it.
Yeah. So that especially from about here down, people are pretty unconscious of how they use their bodies. So sitting positions, sleeping positions, territorialism. This is a big one for humans, having their own one corner of the couch that they always sit on, and that's their spot. And like Sheldon in The Big Bang Theory. I don't know if you get that TV show in Australia, but it's funny. You do? Okay, yeah. So Sheldon has his spot on the couch, right?
Well, we're not that isolated down under.
That's good. I didn't know if it was just a North American show. But anyway, so we all do that. We all have our spot on the couch that we hang out in, and then the TV set is somewhere over there, so we're always turning our head one way. Getting the furniture reorganized so that you can see the TV from any angle. And avoiding pain rather than trying to fix it later, just avoid it in the first place by adapting yourself consciously to your own body and organizing it in space in a comfortable position, in various positions, not just always the same one.
Fantastic. So I think there's been a great episode. There's been lots of great tips through Diane. So before we leave, I want to get after 50 years, almost 50 years of experience, I want to get your top 3 tips for physiotherapists today to help them bring themselves into the 21st century.
Oh my gosh. Well, the internet has already come along. So that's been a huge boon to physiotherapy. Just get on there, read. Hello. We all know how to read. So let's do some more reading and not just use Facebook for, friends and family. No, get into it, get into the groups, get learning from each other. So simple, for example, kind of an old-fashioned discussion group by now, because it's now 20 years later, but it was so helpful for me So internet is a big one. Another tip would be let go of old, outdated ideas. And Neil says, conceptual hallucinations are such that if you are constantly, it's sort of like positive feedback loops. Your way of thinking is going to reinforce your way of thinking. But if you can step back and think, okay, what if I thought about it this other way or from this other angle? Basically, critical thinking. That's a big one. And third one, I don't know. Just keep going. Keep going. The more you just keep going, the longer you'll be able to keep going for. Case in point.
I think that's good advice. Something I'll definitely continue to work on there too. So where do people find out more about you, Diane? How do they find out more about your courses?
I have a website. It's called Neuromodulation.com. And I have all of the upcoming workshops all listed on there. It's just a way for me to keep track of myself, really. But other people are certainly welcome to look up stuff if they want to there if they want to join in a workshop. And also there's a directory. It's pretty kind of like totally by volunteer. If somebody wants to be listed as having taken a dermoneuromodulating workshop, they could be listed in this directory. Doesn't matter what profession you're from. I do want to point out, while we're on the topic of the website, is that the term dermoneuromodulation or dermoneuromodulating, I licensed it with Creative Commons, which means anybody can use it. I don't own it. You don't have to pay a fee or anything like that. It's like anybody can use it if they choose to and want to for whatever they're teaching, hands-on kind of work. That way nobody can build a modality empire out of it, including me. I'm letting it go off into the planet, however far it wants to travel. Yeah. And people can teach it if they want to. They don't need my permission to teach dermoneuromodulating. If they want to teach it, that's fine. As long as they're talking about the nervous system, we're good,
Yeah. Stay true to those philosophies.
Mm-hmm.
Now, I think it's been a great episode, Diane. It's been an absolute pleasure having you on. I really hope, I look forward to hopefully catching up with you when you come and run a couple of courses here in Australia in a few months. But thank you very much for your time today.
It's been a pleasure for me too. Thank you, Stephen.
Thanks, Dan.